All right, good afternoon, everybody. Thank you again for joining us for the second episode of the STAR Center's spring webinar series here, Administrative Strategies to Reduce Burnout. Today, this afternoon, we'll be discussing the topic, In Search of Joy in Practice. Just a quick bit of housekeeping here to get us kicked off. Just an overview, ACU is a nonprofit organization. We focus on recruitment and retention for healthcare professionals in underserved populations. This presentation today is brought to you by our project, the STAR Center, Solutions Training and Assistance for Recruitment and Retention. You can find all sorts of tools, reports, data, and more presentations recorded, like the one that you're witnessing today, on our website at chcworkforce.org. On the line today, you have myself, Mariah Blake, and my colleague, Suzanne Spear, will be kind of manning the background once we hand over controls to our presenter for this afternoon. So our contact information is there on the screen. Please feel free to contact us at any time with questions, comments, any of that. A couple of little tidbits. We are recording today, so you can review this at a later date, share it with your colleagues, and just come back and keep learning. We hope that you will ask questions throughout the presentation. We'll have a bit of time at the end for some Q&A, but if something pops up and you just really need an answer right now, please feel free to drop it in your questions box or the chat box to the right of your screen. And we'll get back to you as soon as we can. Most of all, have fun, enjoy this presentation, and thank you all for joining us. So just one little reminder here. So the questions box, as I mentioned, is on the right-hand GoToWebinar control panel on your screen. So just go ahead and drop your questions in there, and that will direct it to our team of staff members on the line today. You can also raise your hand in your attendees control box, and that'll let us know that you have a question, and we'll reach out to you privately. You can also email me at mblake@clinicians.org if for whatever reason you have trouble with your connection this afternoon. I'll try my best to get you back up and running. All right, and today our presenter on the line with us again today is Lisa Hardmeyer-Gray. And I will just pass the controls on over to her, Lisa. You can take it away.
Hi, okay, welcome everyone, and thank you for joining us on the second episode of this webinar series, Administrative Strategies to Reducing Burnout. If you're joining us for the second episode, the first episode was a little, maybe difficult to absorb the kind of consequences, causes, and implications of burnout. So I hope this webinar will be a little bit more hopeful, looking at some real on-the-ground, in-use strategies to overcome burnout and really change it to something more in line with finding the joy in practice. So today we're going to look at various studies and initiatives to shift the conversation that's shifting from just addressing burnout to looking at more of a stance of finding the joy in practice. Hopefully you'll leave with some organizational strategies to enhance provider wellness. And today we're really going to focus on the study that I'll be highlighting in a bit. There's 7 steps to that study, or 7 innovations, as they call them. We're going to be really diving down and looking at 3 of them: pre-visit planning, pre-appointment lab tests, sharing care among the team. There's going to be 2 different places where we look at the team. And then lastly, in-visit scribing and assistant order entry. At the end of the webinar, we're going to be joined by Dr. Carolyn Halley, who is the lead medical provider here at Health Point in Kent, the FQHC. And she's going to talk about the Scribe program here. And she was the one who implemented it, so that might be some good additional information. So I wanted to start by talking about the shift in conversation. I've been following this track of burnout and burnout prevention for some time, and I've just noticed that the research and a lot of the conversation has shifted from burnout to burnout prevention, which had pretty negative connotations, and a little bit too much focus on what the provider could do. And like I mentioned last time, a lot of the factors that are causing burnout don't really lie in the provider themselves. It's so much more of the changes in healthcare that have pushed this burnout to be what it is today. So people are realizing that it has to go beyond just burnout. Some of the studies show that a third of physicians in primary care, there are only a third of physicians in primary care compared to half in other countries. So of all the physicians that are in medical schools in the US, only 1/3 are going into primary care, which is causing a huge shortage. And obviously we're looking at retention, but when you start thinking about recruitment, the pool is getting smaller and smaller. So with all of the things that we talked about in episode 1, we looked at what burnout is, we looked at the causes, the symptoms, started to look at how to measure it, and kind of started planting some seeds about how to start thinking about what to do about it in your organization. So all of those factors about why it's so prevalent today and why it's so important, it's becoming a huge priority for health service researchers, for policymakers, and for medical educators. So the conversation has to go beyond preventing burnout to really change the way we deliver care. And I love this quote on the left: there can be no joy in living without joy in work. So I think this is a beautiful movement in a way to really start thinking holistically about how to bring that joy, that passion, that fire back to what providers got in the business of doing in the first place. So just want to start out with a poll question. Turning it back to you, Mariah.
Okay, so this first poll question talks a little bit about how would you rate these areas in your organization? So talking about how time spent by physicians documenting visits. So how much of a problem is the time spent by physicians who are documenting their visits? Do you think that it's very problematic, somewhat problematic, or not a problem? So if you could weigh in there and just let us know what you think, how you feel about that specific question, that would be great. Okay, so it looks like that 38% of you said that it was very problematic, 58% said it is somewhat problematic, and 4% said it's not a problem. So the very vast majority of folks at least think that it's a problem in some capacity. So it's definitely something to think about as far as all the documentation that has to occur. And that's certainly something that with EHR we hear all the time. So thanks for weighing in, everybody.
And I think we're going on to the third, it broke this question out into 3 questions, correct?
Okay, great. So let's go into the second part of the poll question. Okay, so how would you rate these areas in your organization? So the organization itself and predictability of your office visits. So do you think that this is problematic, somewhat problematic, not a problem? Now, Lisa, if you wouldn't mind just sort of extrapolating on this question a little bit, sure. About what you mean by the organization and predictability of office visits.
Yeah, really, it's how chaotic is the office visit? Do the physicians feel that they have the information they need? Do they know what the agenda is going to be? Does the agenda change? Do they have the lab results? So how chaotic are the visits, and how much of a problem are you hearing that is to providers?
Okay, thanks so much for clarifying that. So we had 9% of the folks that responded say it's very problematic. 73% said it's somewhat problematic, and 18% said it's not a problem. So almost 80% say that it's at least some sort of a problem in the organization.
Okay. Okay, and then the third part of this question, because we're looking at these three pieces, documentation, visits, and then time spent. Oh, here we go. Okay, right. So ability for patients to see the primary care provider.
Okay, and we'll wait for that last one to launch. Great, thanks so much. So yeah, so how much of a problem do you think it is for your patients to see their primary care provider on the same day as their need arises? Do you think it's very problematic, somewhat problematic, or not a problem at all? Okay, we'll just give it one more second or so. Perfect, thanks so much. Okay, so it looks like 74% of the folks that answered this poll said that it was either very problematic or somewhat problematic. So that's a lot too. So it looks like that these three areas, so the documentation, the organization of the day, and then also the ability to see their primary care provider is at least somewhat of a concern for you all.
Okay. All right, so the next slide. So those are the three areas that we're going to highlight, and this came from the study that, again, I'll be talking about a little bit more. Okay, so really, ultimately, we're talking about provider well-being. And again, hold on a minute. Okay, looking at provider well-being. So the figure on the right, looking at the three domains of real professional fulfillment, and this is from Stanford Medicine, looking at the culture of wellness, the efficiency of practice, and personal resilience. So last time, episode 1, just looked at the overview of burnout. Today we're going to look at some efficiencies of practice on the ground, innovations that are currently happening that have been studied. The next, those will be the next 2 sessions, and then episode 4 we'll look at the culture of wellness, and episode 5 we'll look at personal resilience. And again, just a caveat, I come at this from, I'm a behavioral health person working in a community health center, done a lot of work around burnout and mindfulness. And my researcher hat really comes from my background in documentary filmmaking. So I have not operationalized the processes that I'm going to introduce you to. I hope to bring people on who can, or at least put you in touch with resources. So if you're thinking of implementing some of these practices, there will be some resources of how do I go about doing that. So the 2 areas, the 2 documents that I want to look at, one is the IHI framework for improving joy in work, and that's really how to start thinking about organizationally what to do to have the joy of work become a measurable metric. The research project highlighted on the right is the one I'm really going to look at today. In Search of Joy in Practice, a report of 23 high-functioning primary care practices. This study was done in 2013. I had invited one of the lead authors, Christine Sinsky, to participate. She wasn't available, but she really appreciated that we were highlighting the work, and she has a website also with lots of resources. And this is also a place maybe to say that the Association for Clinicians for the Underserved and the STAR Center will be moving into this kind of initiative, I believe, in the next year. So just want to keep pointing you back here for resources as you really rethink your organization. So the study. So the authors, they really wanted to ask the question in face of kind of the dismal situation around primary care. They wanted to know, are there places where physicians and other staff are thriving? have some practices found innovative solutions to the challenges of office organization? What are the common themes from which others can draw hope and inspiration? And what are the specific innovations? So they looked at 23 high-functioning primary care practices from different geographic regions. They looked at FQHCs, small private practices, large integrated delivery systems, academic medical centers, the VA. And the study included site visits to each of the sites. The authors, usually one per site, visited each of the sites, shadowing physicians and their teams for a day, meeting with administrative and clinical leaders. They also used a questionnaire and did follow-up email conferences with leaders or practitioners. And they also, in addition to the study, they wrote an excellent white paper that dives a little bit deeper into some of the findings that I'd encourage you to look at. So the real premise of this shift, again, is physicians want long-term healing relationships to help people in need. And what they found is that the factors that increase satisfaction are having mastery within their field, realistic expectations, again, this deep relationship with patients and staff, efficiencies, and control over the work environment. And what they ended up finding after interviewing all of these primary care sites and looking at many other organizations to look at what the challenges are, it came down to these 5, which they're looking at: chaotic visits, EHR, which was supposed to really kind of cut down on the workload, is actually pushing more work to physicians, and how much time is spent with physicians, even in the office visit, on the computer versus face-to-face patient time, which is highly dissatisfying to most providers. Inadequate support, time documentation, and teams that function poorly. So those are the challenges. So the innovations that they found that we're going to dive a little bit more deeply into are pre-visit planning, pre-appointment lab tests, looking at a whole team approach. And again, this isn't just assigning tasks to team, but really sharing the responsibility. Scribing, getting some of the physician time off the computer, off the EHR, and really that face-to-face time with the patient. And looking at prescription renewal work out of the practice. And then inbox management, improving team communication, which we're going to highlight next time, and then workflow mapping. So these are the innovations that they found as they went around to these 23 different primary care sites. And then I'm going to turn it back to you, Suzanne, for the next question.
Great. So I'll give Mariah.
No, you know what? Hold on. That's coming after. Let me go into this first one.
Oh, so sorry.
Yeah. Sorry. Okay, so the first challenge that they find, primary care visits are often disorganized and rushed. The innovation that they found is these 3 buckets: pre-visit planning and pre-visit lab tests can reduce the total volume of work and can save time and improve care. Getting lab tests done a few days before appointment so that when the physician and the patient are together, they can discuss the results, engaging in shared decision and decision-making during the visit. And then you can see the results on the far side can eliminate time, at least an hour per day of post-appointment result reporting. So I'm just going to talk a little bit about a couple of examples. And again, in the white paper and in the study, they've highlighted where these organizations are. I'm just going to kind of put them in their buckets. The first one was done at a private clinic. And this was about the pre-visit phone call. So what they do, this is called Fairview Clinic, the medical assistant conducts a pre-visit phone call 2 days before the appointment to address medication reconciliation, agenda setting, lifestyle issues, advanced directives if appropriate, even depression screening, and updates to social and family histories. So the MA places these calls during short breaks between rooming throughout the day. And for the most complex patients, the pharmacist may make a call to perform pre-visit medication reconciliation. So looking at pre-lab, this is at the Mayo Red Cedar Clinic. One of the providers there actually has 2 nurses perform chart reviews a week before the patient's appointments and orders condition-specific lab and cancer screening by protocol. And because of this pre-visit planning, this provider routinely has test results at the time of the appointment, which allows them to explain the face-to-face results, engage the patient in the decision-making using motivational interviewing or other strategies, and eliminates that time of post-appointment results reporting that day. And then another innovation that goes along with that is actually thinking about pre-planning the next visit. So this was at the Medical Associates in Iowa, another private clinic. They pre-plan the visit at the conclusion of each visit. So lab and other tests are scheduled to be completed a week before the next appointment, which can be scheduled out as far as 1 year. And the advanced pre-visit planning eliminates the need for staff to review charts, order tests by protocol. It allows for customized test ordering in context and makes it possible for the patient and the physicians to discuss the results at the appointment. So these are some innovations around how to really think about all the things that can be done ahead of time so that when the provider is there with the patient, it's more one-on-one time, less chaotic. They know what they're doing. They know what they're there for. And, you know, as one of the providers said to me that, you know, the agenda setting can be done by the MA, and that's a good starting place, but oftentimes patients will bring up something with the provider that they wouldn't tell an MA over the phone. So always room for that to shift, but at least there's a basic premise and not thinking you're seeing them for 2 things and then 4 or 5 other things get brought up. So sorry, this is the next question, Suzanne.
Okay, great. So another poll question, do you think that the support staff in your organization can take more responsibility for license appropriate aspects of care? So I think maybe another way of saying this also is, do you think that they could be doing more and working to the type of their licensure?
Exactly. Mm-hmm.
We'll give everyone a second to respond to that. Maybe about 5 more seconds. Okay. So 85% of you say that you really think that they could be taking more responsibility and doing things more to practice to their top of their licensure. And I think, wow, that's astounding, Lisa. Really does say a lot about what, you know, all the support staff could be doing to help with put that joy in practice back for our providers.
Yeah, and I don't know the research on asking the question to the support staff, but it would be interesting to see what the statistic might be asking the support staff. For instance, how much more responsibility would you like to have in taking care of the patients? And my guess would be it's pretty high, because when we look at, you know, so much of what we'll talk about in employee engagement is employees want to have, they want to have autonomy. They want to work in teams that make a difference. They want to have more responsibility. And so it's working to the top of their license, but it's also working to the top of their connection with the patient and the mission that they're there to do as well. So I love having these questions. It gives me so much information about the audience and what you're thinking about. So the next, let's see. So pre-visit planning, all of those things that go into the bucket, pre-visit planning, doing labs ahead of time, how much of this can be shifted to that support staff? The next challenge that I want to talk about that they highlighted was that patients can't see their provider the same day as the need arises. And again, with the poll that we did, it looks like everybody is at least in the problematic to somewhat problematic. And the innovation here is to improve access and increase adherence to clinical guidelines. It means building this additional capacity and transforming the roles of medical assistants, nurses, health coaches, so that they assume more responsibility for elements of care, and extending this team to include social workers, behavioralists, nutritionists, and pharmacists. And again, the results here are that you can improve the PCP satisfaction outcomes, but we'll get more into this later, that as you can shift some of these duties across the team, the provider maybe just will have better work satisfaction, but in some cases it's showing they can actually see more patients in a day because they're not doing all of these other things. So I wanted to give you a couple examples. One area in adding this capacity is expanding the MA nurse rooming protocol. This is through another private clinic. The MA role was transformed from a person who just answers phones and escorts patients, obtains vitals, to a partner that helps provide team-based care. And the rooming of the patient was expanded from 3 minutes to 8 minutes, and now includes recording current medications and allergies, agenda setting, form completion, and closing care gaps. So for example, the MA reviews all the health monitoring reminders, gives immunizations, and proactively books appointments for mammograms. And the goal is to meet all of the needs of the patients while in the room, rather than leaving the loose ends to be addressed through a more time-consuming process at the back end. Another example, and this is from an FQHC in Denver, or near, there's several sites in Colorado, the Clinic of Family Health Services. Their medical assistants have taken on care responsibilities for diabetes and immunizations that are empowered through standing orders. For example, the medical assistants perform point of care A1C testing, diabetic foot exams, arranging appointments for retinal exams, and administer immunizations using EHR decision support. The medical assistants also use the templates to take detailed condition-specific history of present illness for chronic illnesses like diabetes, asthma, and ADHD, and perform substance abuse and mental health screening. And these screens generate a note that the provider can quickly review, and they've expanded their MA pre-visit to 10 to 15 minutes. Another area that they're looking at is establishing the standing orders that enable other team members to address care needs. So again, at Clinica, and I'm hoping to get someone from Clinica for next week. They've created standing orders that empower RNs to diagnose and treat simple problems without clinician involvement. These include strep throat infections, uncomplicated conjunctivitis, ear infections, head lice, STDs, uncomplicated urinary tract, and some Coumadin management. So these services can be provided by phone or face-to-face nurse visits. And then there's another clinic, Fairview. They received a grant from a local health insurance to provide its model of care. And they developed a new mental model, pulling doctors out of the infrastructure, typing EHR, and getting them back to being present to the patient. And one of the internists states that the standardized work is done by the team. I don't have to think about immunizations and colonoscopy. The MA takes care of these before I get in the room. So much care can be done by a team, and we just have to really think about, you know, what are they licensed to do and what can they be doing that is at the top of their license. Also, there's an area, again, Clinica has done a lot of innovative things. They're extending responsibilities for health coaching and care coordination, as well as integrated behavioral health to non-physician members. So, for instance, behavioral change counseling has been delegated to non-professional managers, to health coaches, who provide patient education and smoking cessation counseling, and help patients with chronic conditions and set goals and formulate action plans. And these can be done by mental health professionals, social workers, psychologists, counselors that are all integrated into the primary care team. For example, at Clinica, if an MA uncovers depression symptoms, she'll administer the PHQ-9 without having to talk to the behavioral health person or the physician. Just give the patient the PHQ-9 and then get a hold of the behaviorist. Warm handoffs between the MA and the nurse, case manager, or mental health professional at the close of the visit ensure good communication, but the physician may have minimal involvement with this process. And I see this at this clinic where, you know, we have a great team handoff system, but sometimes they're looped into conversations around mental health issues that sometimes are beneficial, sometimes take up time with the physician that wouldn't be necessary. This is another example coming from another private clinic. People will be relieved and probably envious of some of these models of care where they have 3 MAs to 1 physician. But in this particular clinic, they have 3 RN health coaches working with 7 physicians and 5 PAs, and each RN working with the same 3 to 4 providers for consistency. And their responsibilities include reviewing the patient charts to queue up labs to be ordered by the physician at an upcoming visit. And the physicians really appreciate the efficiency of having the orders pre-selected and ready for their electronic signature. Sometimes health coaches will meet with diabetic patients in person or over the phone, working on diet, insulin adjustment, healthy lifestyle. And the health coaches manage patients who drop in for blood pressure checks, adjusting Coumadin doses, and working with the patients on goal setting. So really expanding that team. Another example is really sharing the care through panel management. And this is an example that comes from another FQHC. Panel management responsibilities are built into the job description of every member of the care team. So MAs have outreach responsibilities to update lab work. And again, this is responsibilities, not just tasks that the provider is then responsible for, but conducting depression screening and referring patients with diabetes for annual eye and foot exams. And this FQHC has found that there must be a dedicated and protected time. I think we see that with a lot of the MAs that, you know, that they can be called to do so many things at one time. So having that protected time, that can really help them just focus in on that. And the staffing performing panel management must be trained in health coaching, how to effectively talk to patients. So I'm curious of the next question. Suzanne, can you take this?
Sure, absolutely. So looks like this is the last full question today, but it says, do you hear from your providers that they're frustrated with the amount of time spent documenting? So I have a feeling I know the answer to this, but we'll leave it open for about 5 more seconds and give folks that would like to answer some time to answer. Okay, so no surprise here that 98% of providers are frustrated with the amount of time they spent documenting. So, you know, this is, wow, yeah, overwhelmingly that it's a problem and it's an issue. So so I'm really excited to hear this next part of Lisa's presentation to give some ideas about some things that that health centers can put into place to help alleviate some of that stress and that tension that they have that comes from all the documentation that they are required to do.
Okay, so let's move on to the challenges then in the innovation. Again, this goes back to having a team that can do more above their license and more that they're being asked to do. Bringing them into the responsibility, bringing them into scribing, bringing them into areas of caretaking or being part of the care team that they maybe actually want to do. So if we look at the scribing, hold on. I have just been joined by Dr. Carolyn Halley here at HealthPoint, and she brought the scribing program in. And while I'm queuing up this next segment, I'm just going to ask Dr. Halley, can you tell me a little bit about how the scribe program came into being at HealthPoint and what you see is working, what you see as are some of the challenges?
Sure, thanks, Lisa. I'm the lead provider here at the same clinic that Lisa works at in Kent, Washington, and have been here about 10 years. We probably started the scribe program about 3 years ago just as a pilot project, and I want to say maybe there were 5 or 10 scribes who were hired through an agency called ScribeX. They do all the recruiting and hiring and training of the scribes, most of whom are pre-med students, and are really highly functioning, highly organized, extremely motivated to learn medical terminology, et cetera, and they do a really great job training them. And after about a year or so of having the pilot program, there were lots of different metrics that were run to see whether it was cost effective and if it saved provider time and other things like that. And it actually took a while because it's really hard to prove that a program like that is cost effective, partly on account of the fact that the way we were paying for the program was through adding an extra visit per session, which if all those patients showed up would more than pay the cost of that scribe. But then you run into the challenge of no-shows, which you run into in primary care, particularly community health medicine, regardless. But the scribe program was kind of being asked to be more perfect on that account than we otherwise are. And I personally, I think in terms of efficiency, that once you add in that extra visit, that it's probably a wash. I'm not sure that I do become more efficient overall. I don't think that's where the gains are, actually. I think your notes are far better, so they may not be done any more quickly. Maybe they would be, but once you got the extra patient, maybe not. But the documentation in terms of the history is just, they're not even in the same ballgame in terms of now suddenly you're not trying to talk to the patient and write it down and dissect the chart and look for things and examine the patient all at once. You're relieved of one of the major components, which is documenting the information the patient's giving you. And what that sort of leaves is really a transformed visit, I think, because it's not just that you're not documenting, it's that you're actually looking at the patient and talking to the patient. And to me, it's not so much about efficiency or something that's quantitative in that way. It's a lot more qualitative that it, for me at least, really has brought the joy back to medicine because what I'm doing is interacting with the patient rather than with the computer primarily. So that, certainly has payoffs, even financial payoffs in terms of retention and of providers, but that's a lot harder to measure, of course. So anyway, in terms of justifying the program, we went around and around for quite a while, and ultimately it was decided that it was worth it, and we've expanded the program. I think we might have at least 20, maybe 25 scribes in the organization now.
I have a question for you, Carolyn. How do you decide what providers get a scribe and which don't, and how much in demand are they?
Well, certainly a big part of it is who desires one, but there are more people who want a scribe than we have available right now. And so then essentially there was an algorithm built that has to do at its core with who is at the highest risk of burnout, I would say. So longevity with the organization, productivity or number of patients per hour that person sees. I want to say those are probably the main components.
And what do you notice? What do you notice in the patient interaction with a third person in the room?
It varies. So one of my first interactions with the scribe, when I said, this is Matt, and he's going to be typing for me, and my patient actually looked at me and was like, well, what's wrong? Can you not type? Like as though I had some sort of a new disability or something. And I said, well, no, I can. I'm just, he's going to do that. And she was like, well, what are you going to do? It was really illustrative, because I think it just kind of tells you how much patients and providers have really just accommodated this interference. And I don't disagree with electronic medical records. I think we absolutely need them, and there are many more benefits than there are disadvantages. But there's this interference in the visit. And I said, well, I'm going to be talking to you. And so we had kind of a good chuckle about that. But so I think in general, patients are okay with it. There are patients, I'm a female provider, my scribe is male, and that definitely has been an issue on many occasions, even probably at least one a day, where a female patient is either going to be partially undressed, or we have some patients who are from Pakistan particularly, who just don't want a man in the room, period, much less, a lot of them are pregnant, even if they're showing their belly or any skin that's not sort of hands or face, they just don't want a man in the room at all. So there are times when he just can't come in with me, or where I'll say, I'm going to have Matt step out now so that I can listen to the fetal heart tones or whatever. Some of the patients really like Matt. He's very sweet. He loves kids, and half the time I have to, well, he's really, really good, but he does often make little faces and smiles with the babies, and gets distracted from doing his typing, but he's very good.
And I'm going to ask Dr. Halley another question, and that is, some of this team-based care, and this is unscripted, I haven't asked her that I was going to ask this yet, but, some of this team-based care is, it's great to take the responsibility off your shoulders, but there is really a we, and you're moving from I as the physician to we as the healthcare team. And how is that for you, having practiced? Does that ever come up that you think about? It's not just me the patient is connected to, but it's we, and we're all engaged in their care. How do you think of that?
Yeah, I think that's absolutely central to the model that we're working off of. There are lots of different models of primary care now, partly born out of just the overwhelming, voluminous nature of primary care. And 2 or 3 of my 10-class residency class are working in what we maybe 10 years ago would have called concierge or boutique clinics. I think they're no longer only geared towards wealthy people, but where they have a very stripped down team. They've got a receptionist, I think they do all their own vitals. They've got a number of people kind of in the cloud doing referrals and things like that. But essentially it's just them and other providers who are in the clinic, and they their patient volume is way lower because they're not having to see patients in order to provide salaries for all the other staff. So that's one version, and that I think works really well for some providers. Personally, and this is just personality, I think to me it's worth it to see more patients, but have a community of other providers and other team members to work with, including behavioral health that are right outside the door that I can grab and bring in. Nurses, nutritionists, we have acupuncturists, natural medicine doctors. So we have a really rich team. And for me, that's just something that I want. I want to practice in a community of people. But there is obviously a downside, which is the salaries have to be paid by something, and they're paid by basically that provider-patient interaction.
Thank you. And I've been asking Dr. Halley a lot of questions, but I think it's time to turn the session over to you, the participants. And do you have any questions for Dr. Halley about the scribing program? She also might be able to answer some questions about kind of looking at the team-based care approach.
Yes, thank you, Lisa and Dr. Halley. We actually do have a couple questions that have come through that really have a lot to do with this scribe program. So this first question that came through said that I appreciate many of these suggested innovations. I work in a family medicine residency. I foresee feedback being that these innovations would get in the way of residents' learning. Based on your expertise, would residents be a detriment if they had scribes or if their MAs took on a larger role in the clinic? Do you think, I think what they're asking is like, do you think that it's going to take away from what the resident is learning during their time in residency if they're using scribes and they're using MAs to the fullest extent of their licensure?
Yeah, I think those are two really different questions. Certainly my residency and every residency I've ever heard of incredibly underutilizes medical assistants. And I mean, I think they're pretty sweet jobs for medical assistants, really, because not very much is asked of them because the residents are expected to write their own letters to patients and, do their own EKGs or a lot of things that I don't think they really do need to be doing because they're not particularly skilled work, or they certainly don't need a medical degree. So I think utilizing medical assistants to the full extent of their license, I think that should be much better in residencies, and it's confounding to me why residencies make such poor use of their medical assistants. In terms of scribes, I guess I feel kind of ambivalent about that. I think providers need to learn how to do their own history taking and typing. They need to learn how to do that whole very, very cumbersome visit because, well, for one thing, most practices aren't using scribes. So you don't want to let somebody out of a residency to go out to look for a job in the world, never having had the experience of having to do it all on their own. I don't know if there's necessarily any utility in it beyond that. I guess I'd have to think about that more. But I do think, in residency, it is appropriate that you learn to do kind of the whole scope of medicine.
Right. Thanks so much for answering that question. And we have a couple more. This one says, can the medical assistant be the scribe?
I think they can. That was an idea that we originally had, or I guess we didn't, but some of the administrative people were like, yeah, go ahead, do it. And to which all the providers were like, that's not possible. Our medical assistants work incredibly hard. We lose medical assistants all the time because they can get much easier jobs, 100 feet away at the next door clinic. So it's not possible to just bring them into every visit. You'd have to hire a lot more of them. I will say the company that we work with they do an excellent job of training the scribes, from what I can tell. And I've probably worked with 4 or 5 of them at different times. So they have a very, very rigorous training. It's not the same thing as just saying, hey, medical assistant, come in here and start typing for me. It's the level of training that they have to do exactly the thing that they're doing, which is medical scribing, and really understanding the electronic health record, because they go through training with our electronic health record. It's different than MA skills. So I'm not sure that that's a great solution. It certainly is possible, but I don't know how you would do that without hiring a lot more medical assistants and spending significant time training them. Otherwise, frankly, it's quicker for me to do it myself than to try to get somebody else to understand what I want them to put down when that's not their training.
And I wonder if I can jump in here too. I don't know what the salary difference is between an MA and a scribe.
Oh, MAs make a lot more money than scribes, but that's because scribes are, by and large, I think what we've got is extremely intelligent, extremely driven people who are willing to work for not that much money because they are, the downside is they are going to leave more than likely within a couple of years to go to medical school. So then they're sort of constantly retraining new people, which definitely has its downsides, but what you're getting is a really high caliber, highly motivated person in that position. So yeah, medical assistants, from what I understand, we pay a decent amount of money to the scribe program, but the amount the actual scribe gets is less than what a medical assistant makes.
Okay. And if you want to refer to the white paper or that study, there are some examples of where they used medical assistants and nurses for scribing, but I think it's interesting to hear the pros and cons of actually a scribing service.
Yeah, absolutely, for sure. I have heard personally of some organizations using medical assistants as scribes with additional training. As Dr. Halley mentioned, it's a whole different set of skills. So making sure that they're properly trained and not just thinking that because they're a medical assistant and they know that the clinic, it's not something that they can just do, without that additional training, but making sure that they have the training is great. So next question, and it looks like the last question that we have is, so this particular person said, you have 25 scribes in your organization. How many patient visits per month does your organization have? So I think what he's probably getting at is, does it increase your the ability to see patients quicker?
Yeah, well, I guess I would talk about it more in terms of we schedule 3 patients an hour for all providers, and we don't expect them all to come. So our goal is, I think for physicians now, it's 2.65 patients an hour. If you have a scribe, then you get an extra patient slot per half day. So if you're working 4 hours, you'd have 12 slots, and that would make you have 13. So yes, it does increase productivity. That extra slot, as I mentioned, if that patient comes, will more than cover the cost of the scribe. And then, of course, you just get into the perennial questions of no-shows and what really ends up happening. But the no-show issue is, in my mind, totally separate from the scribe issue.
Mm-hmm. Yeah, absolutely. So sounds like it does. So it's definitely worth, as you mentioned, Dr. Halley, you kind of had to prove its worth, but it sounds like it's.
Yeah, and I think if you look at it on a pure, you could, I think it is probably cost effective, even with no-shows, but in order to prove that, you'd have to somehow quantify all the things that we haven't been able or willing to quantify, like provider recruitment, retention, training, all those kinds of things that certainly equal a lot of money, but we don't have a good way to quantify it really.
All right. Thank you all for answering those questions and for the great conversation today. We're headed towards the end of the hour here, so I just want to jump in with some quick reminders. So just a reminder for you all, there's a copy of the slides in a PDF format that is available for download in the handout section of your attendee panel on the right of your screen. You can download that now. It will also be emailed out to you with the recording of today's webinar by email tomorrow around the same time as today's presentation. We will have a very brief evaluation that'll pop up on your screen as soon as we end the webinar this afternoon. If you could just give us some really quick feedback on how we did today so that we can update and continue to improve for next week's presentation and the remainder of the series. If you could just fill that out for us really quickly, it's only a couple of questions, we'd really appreciate that. Thank you all again for joining us today, and thank you to Lisa and to Dr. Haley for joining us and giving us great content today. Thank you so much. Enjoy the rest of your day, everybody.
Thank you. See you next, or talk to you next week.